Good morning, everyone. So as Cecilia mentioned, I'm going to talk about the heart and the brain this morning. I have no conflicts of interest to disclose, and this is our copyright slide. So really my objectives for this morning is really to just set the tone for the day, because the day is going to be focusing a lot on the brain injury and the outcomes of our patients with congenital heart disease. So in the next hour, I'm going to hopefully help you understand the relationship between the heart and the brain and how congenital heart disease impacts brain health. We'll also do a brief introduction on some of the patterns of brain injury that we see in our patients with congenital heart disease. And most of the talks this afternoon and later this morning will go into more detail about these specific types of brain injury. And then we'll also discuss some of the modifiable risk factors affecting neurodevelopmental outcomes in congenital heart disease and how our program and other programs kind of try to impact these risk factors to improve outcomes of these children. So just to start off, what is the problem? So as we know, congenital heart disease is the most common congenital malformation in children, and it occurs in 1 in every 100 live births. Due to incredible advances in surgery and perioperative care, up to 85% of children with congenital heart disease now survive to adulthood. And now we have more adults living with congenital heart disease than we have children. But despite these amazing improvements in survival rates, the neurodevelopmental outcomes and the trajectory hasn't improved as significantly. And approximately 50% of survivors with CHD have lasting neurodevelopmental disorders. So if we look at this table here on the left, we can see that over the years, particularly with the complex congenital heart disease population, which is the lime green bar, their survival rates has improved drastically. When we look at this table on the right, with the dark line being the psychomotor development indices and the little circles being the mental development indices, we can see that we haven't seen as drastic of an improvement. And this is essentially what we're going to be talking about today. So I'm sure you've seen this chart before from some of our previous presenters, but I'll just highlight it again. So when we look at congenital heart disease, we can see that the risk for neurodevelopmental disability increases with the severity of the heart disease. So in our mild congenital heart disease, we're thinking of things like an isolated VSD or an isolated ASD. Generally, these children do well from a neurodevelopmental perspective. If we move on to our moderate congenital heart disease, these are like a coarctation of the aorta, for example. You can see as they get more severe that you start seeing more neurodevelopmental disabilities. Our severe group mostly has our cyanotic heart diseases like tetralogy of Fallot or transposition of the great arteries. We can see that up to 50% of these patients are presenting with some sort of neurodevelopmental disorder. And then moving to our palliated neonates who have single ventricle disease, these ones, almost up to 75% of these children are presenting with a type of neurodevelopmental disorder. And then of course, our syndromic patients that have an underlying genetic diagnosis are at highest risk for neurodevelopmental disabilities. And when we look at these children and what type of neurodevelopmental challenges they're presenting with, there is a typical neurodevelopmental phenotype of congenital heart disease. We're seeing early on, we're seeing a lot of early gross motor delays and fine motor delays. The gross motor delays usually improve by age 2, but the fine motor delays tend to persist. And that presents in like challenges with handwriting in school, for example. There's also concerns with visual spatial integration, and that presents as challenges in school too, as children are learning how to read and write. Speech and language is also a big area of our children. And while these children usually have intact receptive language skills, their expressive language is usually delayed, and we start picking up on that between 12 and 18 months, and these concerns generally persist. A lot of the times, because these children have expressive language delays, we're starting to see a behavioral phenotype as well. And a lot of these children are presenting with inattention and later on presenting with more mental health disorders like anxiety and depression as well. And then when we look at cognition of these children, we can see that the mean IQ for these children, while normally it's in the normal range, it's on the lower end of the normal range. And when we compare to the general population, we see that the congenital heart disease children do trend lower overall. And this is higher in the acyanotic group versus the cyanotic group. And then also executive function, which is a big one. These children have decreased attention. They have challenges with planning and problem solving going ahead. So, previously our attention has always been on the heart and focusing on repairing the heart. And then once the heart's fixed, that's kind of the end of the story. But now, because we're becoming aware of these neurodevelopmental disabilities, there's a bit of a shift of focus, and now we're focusing a lot more on the brain, and now there's a lot of targeted groups working towards improving brain health in these children. So one of the ways we have done this at Sick Kids is we've created a cardiac neurodevelopment program, and our program has a lot of different arms. We do routine pre and post-operative clinical brain MRIs in our patients with transposition of the great arteries and single ventricle diagnoses. On average, we're doing about 60 patients a year, so about 120 MRIs, routine MRIs a year. Of course, for those babies with abnormal brain MRIs or abnormal clinical exam or seizures, we have a specific neonatal neurology team that is well-versed in the congenital heart disease population and does these consults and will follow these patients as outpatients. We also have a CCCU neuromonitoring program where we've started implementing cerebral function monitoring in our unit, and you'll hear a little bit more about this afternoon. We've also been doing routine genetic testing to capture more of those syndromic high-risk children that might have an underlying genetic disorder that might explain their cardiac disease, but also their neurodevelopmental delay. So we're doing that on every isolated congenital heart disease in every neonate. We also have focused a lot on our inpatient neurodevelopmental cares and empowering parents as well. So we do have a weekly CCCU neurodevelopment round. And then we have a lot of follow-up programs as well. So we have a partnership with our neonatal neurodevelopmental follow-up clinic, and they follow all our babies up until age 3. And then once they turn 3, they will move on to our neuropsychology team, who will follow them until they're 18 years of age. Our neuropsychology colleagues also run our ECMO follow-up as well. So moving on to the origins of interest in neurodevelopment in congenital heart disease. And this really started in the late 1980s during the Boston circulatory arrest trial. And essentially, this was with the increasing popularity of deep hypothermic circulatory arrest as a bypass technique. And they were trying to see if the neurodevelopmental outcomes of children were any different between the deep hypothermic circulatory arrest group versus a low flow bypass group. And they were also one of the first groups to start identifying this specific phenotype of neurodevelopmental delays in congenital heart disease. So essentially what they found was that the longer a patient was on circulatory arrest, the worse their psychomotor development index was. And this was actually where that ideal of less than 40 minutes of bypass time, circulatory rest time came about because once the children kind of bypassed this 40-minute mark, their neurodevelopment was poorer. However, regardless of the bypass technique, they found that regardless, these children did poorly from a long-term neurodevelopment perspective. And we know that the effects of intraoperative cardiopulmonary bypass are multisystemic, but they do have some specific neurologic impairments and effects as well, where they impair cerebral vascular autoregulation, especially for the first 24 hours after being on bypass, and also cause ineffective cerebral venous return. But then there's also these hematologic risks that can increase risk for stroke, and then use of high doses of heparin, which can cause hemorrhage as well. But we know now that because our surgical techniques have improved and these children, their neurodevelopmental trajectory hasn't made quite the same improvement, we know that now that the intraoperative factors aren't the only factors impairing neurodevelopment in congenital heart disease. And now we know that there's this huge spectrum that starts from the fetal period and continues until adolescence. So for the rest of the talk, I'm going to kind of explore some of the other impacts impairing neurodevelopment in these children. So starting from genetics, so we know that there's a wide variety of genetic syndromes that cause congenital heart disease, and many of these genetic syndromes also can cause brain malformations or even just impair neurodevelopment. Some of these examples are, your trisomy 18, trisomy 13, trisomy 21. We also have things like DeGeorge syndrome, for example. So we know there's that clear association and that genetics does cause impairments in neurodevelopment. However, based on the research that's been done on genetics, we know that the majority of congenital heart disease is idiopathic. So genetics doesn't really explain the whole story. At SickKids, we've been doing routine microarrays in congenital heart disease with the intention of using that information to be able to modify what kind of developmental follow-up and support a child gets. And when we've been doing this on isolated congenital heart disease, specifically focusing on the types of heart disease that are usually associated with a genetic change. As you'll note, we've excluded transposition of the great arteries from this study because TGA isn't usually associated with genetic change. From our findings so far, we've had about 50% of the chromosomal microarrays that we have sent on these babies have been negative, but we have had a 27% pathogenic rate, and then 14% of our tests have come back as a variant of uncertain significance. So those children have been referred to genetics, and some of those variants could become pathogenic with further investigation. The pathogenic rate that we've been getting is consistent with what the literature reports, that in congenital heart disease, about 20 to 30% of them can be explained by genetic or environmental cause. So moving on, essentially once the Boston circulatory arrest trial was done, there were some groups that tried to look into the brain imaging of these children. And the first group to really do that was Stephen Miller and Patrick McQuillan at UCSF. And they had a small group of neonates with congenital heart disease that they were able to do brain MRIs on. And they used a specific technique called fractional anisotropy. And essentially what fractional anisotropy does is it measures the organization and the maturity of the white matter. So the higher the fractional anisotropy is, the more structured and more mature the white matter is of these children. And what they found was overall in the neonates with congenital heart disease that they studied, they found that they had an overall lower fractional anisotropy compared to controls. So this is what this graph here is showing. So after this study, a lot of other groups started looking at other techniques and components of brain maturity. So Catherine Limperopoulos out of Boston looked at NAA versus choline ratios. And these were mostly fetal images. And what she found was that the children with congenital heart disease had significantly lower NAA to choline ratios, indicating more immature brains. And then she also looked at the total brain volumes of these children. So again, the red line being the controls and the blue line being the children with congenital heart disease, that starting in the third trimester, we start really noticing a difference in the total brain volumes, with the children with congenital heart disease really dropping off and having lower total brain volumes compared to the controls. And this white matter and brain volume changes isn't only a fetal or a neonatal issue. This actually persists well into adolescence as well. So this study by Rollins out of the Boston group took the original Boston circulatory arrest cohort, which was mostly focused on children with transposition of the great arteries, and rescan them using fractional anisotropy techniques at 16 years of age. And then at the same time, they also did some cognitive testing as well. So what they found was that the fractional anisotropy continues to be low in the adolescents with congenital heart disease and compared to controls. And when they correlated the fractional anisotropy with the cognitive testing, they found that the higher the fractional anisotropy was in the children, the higher their mathematics scores were. And then they found an inverse correlation between fractional anisotropy and ADHD symptoms reported by parents. So the lower the fractional anisotropy was in the right precentral white matter, the more the parents were reporting ADHD symptoms in their child. So why do we think this is happening, particularly in the neonatal and fetal period? Why are we seeing lower brain volumes, more immature white matter in these children? And this is a figure taken by one of Mike Seed's papers, who you've probably already heard from or will hear from in the future. And this is a really great image showing how the brain oxygenation looks in children with different types of congenital heart disease in comparison to a child with normal circulation. Obviously with the darker color being more deoxygenated blood. And essentially this is demonstrating how, in fetal circulation, we have the oxygenated blood coming through the placenta, and through the process of streaming is going across the PFO, and preferentially giving oxygenated blood to the brain. But when you have congenital heart disease, so transposition of the great arteries, for example, you're not really getting that oxygenated blood preferentially going to the brain, and that potentially has some big impacts on how the brain is developing over time. And you can see that there's different variations of this with the hypoplastic left heart syndrome and with the tetralogy of Fallot group. And then looking at this graph here, this is also from a paper from Mike Seed. Essentially what they did was using MRI techniques, they were able to calculate the flows and the saturations in the ascending aorta and the umbilical veins. So when they looked at the aortic saturations in children with congenital heart disease compared to the normal controls, they found that their aortic saturations were much lower, which makes sense based on the previous images we saw. They also looked at blood flow, particularly through the UV. And this was interesting too. They found that children with single ventricle disease had much lower flows compared to the biventricular, compared to the normal controls as well. So not only are they getting less oxygen to the brain, but they're also getting decreased blood flow to the brain. And then this correlates with the brain volume. So when they plotted this, the aortic saturation in these fetuses and compared that to the brain volumes of these fetuses, they found that the aortic saturation correlated with the brain volumes of these children, with the children having the higher aortic saturation, so getting more oxygen to the brain. Those children had the higher brain volumes. So because of the immature brains in congenital heart disease, these children are at higher risk for brain injury. And not only is this injury happening postoperatively, but we're also seeing a lot of injury preoperatively. So different studies will report different values, but the majority are reporting around a 47 to 50% rate of preoperative brain injury, and then it's around a 70 to 74% postoperative brain injury. So you'll hear about all these different types of brain injury in more detail today, but I'll just give a brief overview of each of them in this talk. So just to share a bit of our data from sick kids. So as I mentioned, we do routine preoperative and postoperative brain MRIs in all our children with transposition of the great arteries and to have a single ventricle diagnosis. And then we also do clinical brain MRIs as needed. So in a child that's presenting with seizures or a child that has hypotonia, for example. So when we looked at our MRIs, 42% of them were normal. And then the highest rates of type of injury we saw was stroke. And the majority of strokes we saw were those small punctate strokes, which I'll describe a little bit more later. White matter injury is one of the common ones that we've seen, with 12% having a more watershed or deep gray matter type of injury, and then 4% presenting with a cerebral sinus venous thrombosis. And then we also had around 6% of our babies presenting with some sort of congenital brain malformation. Our rates were showing around 43% of our babies had pre-op injury and about 58% of our babies had a new post-op injury. So just moving into white matter injury, and I'll spend a little bit more time on white matter injury compared to the others because I don't believe the other presenters will be going into white matter injury in too much detail. So in our cohort, we've been seeing around 20% of our babies presenting with pre-op white matter injury and around 44% presenting with post-op new white matter injury. And just as a note for all the imaging I'll be showing today, if something is bright on the MRI, then that's usually an area of ischemic injury. So we can see in this MRI, there's a couple of little punctate lesions in the white matter here. So those are white matter injury. This is an example of diffusion weighted imaging. So you'll see these really bright white areas where there's ischemic changes. So these are some punctate areas of white matter injury. And then same with this one, we have a bit of a posterior area of white matter injury in this one. So essentially when we think of white matter injury, it's an injury of brain immaturity. When we look at the cell type in the white matter, that's primarily the cell type that consists, that makes it up is what we call an oligodendrocyte. In a term baby that doesn't have congenital heart disease, we would expect that the majority of their white matter is made up of mature oligodendrocytes. But as we know, and as we've discussed so far, the brains of term neonates with critical congenital heart disease have immature white matter. And they've been able to kind of take that back and say it's immature by up to 4 to 6 weeks gestation. So when we look at their brains, we see that they're made mostly of pre-oligodendrocytes, which is an immature version of the oligodendrocyte. And then we can kind of see in this graph here that the pre-OLs are kind of peaking at around 30 weeks gestation and slowly start coming down around birth, with more mature oligodendrocytes increasing around term age. And why do we care about the pre-OLs? Well, they're more vulnerable to hypoxia. So when we have a hypoxic infant with congenital heart disease, then they're more likely to develop white matter injury because of this. The other interesting piece is that I'll kind of highlight what the dotted line means here, is that if the fetus or the neonate experiences some type of brain insult, then it actually delays the maturation of the pre-oligodendrocytes. So if our babies' brains are constantly exposed to lower oxygen saturations and lower blood flow, then this is also delaying their ability to mature their pre-oligodendrocytes to mature oligodendrocytes, which are more robust and resistant to injury. And then when we look at the pattern of white matter injury in the brains of term babies with congenital heart disease, we notice that they do follow a specific pattern. So if we're looking at these images, this was a study done out of sick kids by Dr. Stephen Miller and Jesse Guo. And essentially what they did was they plotted each spot of white matter injury. I'm using this graph here, where the white voxels, so you can kind of see them over here, are pre-op injury only. The blue voxels are post-op injury only, and the magenta voxels are pre and post-op white matter injury. And what they found was that the white matter injury in term infants with congenital heart disease is happening more in an anterior posterior type of pattern. And this is interesting because this actually correlates with the maturation of oligodendrocytes. So oligodendrocytes tend to mature first in more the central areas of the brain, so more here. And then they mature posteriorly and then anteriorly. So the fact that our babies with congenital heart disease are presenting with mostly anterior and posterior white matter injury correlates with their delay in oligodendrocyte maturation. They took this study a step further and actually compared the white matter injury in babies with congenital heart disease at term age and compared them to infants that were born preterm without congenital heart disease. And they found that the pattern was actually quite different. The children that were born preterm tended to have more of a central pattern of white matter injury as opposed to the anterior posterior pattern that our children with congenital heart disease have. And that just correlates with where the brain maturation is of our children with congenital heart disease, where we're estimating their white matter injury is more around the 32, 34 week gestation mark, whereas the preterm babies had much less mature white matter. And then when we look at white matter injury in comparison to bypass and deep hypothermic circulatory arrest, we can see that there is a correlation between the severity of white matter injury and the duration that they are on bypass for. But as we know, the most consistent risk factor for white matter injury is postoperative low cardiac output states or low blood pressure hypotension. So moving on from white matter injury and to stroke. So strokes are very common in congenital heart disease, particularly the punctate lesions. We can see rates as high as 60% in those with cyanotic congenital heart disease. The majority of the small punctate strokes that we see are silent infarcts, and the only reason we're picking up on them is because we've been doing these routine images pre and post-op that we've actually been picking them up. The majority of these small punctate lesions have low progression of the infarct, low risk for hemorrhagic transformation. So usually there's no delay in clinically indicated surgeries. And usually we consider their surgery as the treatment for their stroke because, for example, if it's a baby with transposition of the great arteries, we're doing a complete repair. They no longer have any shunts in their heart to allow clots to travel up to the brain. So that should decrease their risk for stroke significantly. And there are a lot of papers discussing how punctate strokes are thought to be related to preoperative balloon atrial septostomy procedures and transposition of the great arteries. And that could, the exact mechanism is unclear, but it's thought that, that tissue damage causes a bit of hemorrhage in that local area, which then causes some emboli that can then travel across that new shunt in the heart up to the brain. So the literature reports a 20% preoperative stroke rate and a 10% postoperative stroke rate in congenital heart disease. The majority of the pre-op strokes are those small punctate lesions that we see like this. And the post-op strokes are more commonly the more severe territory strokes that we see. And those ones are obviously the more significant injury to the brain. These larger strokes are much more common in babies that have palliated hearts or delayed repair of their cyanotic lesion. And they still have that shunting across the heart, which allows clots to travel up to the brain. So those children generally have the more severe strokes that we see. We also have our high rates of cerebral sinus venous thrombosis in our children with congenital heart disease. So the previous strokes that I was discussing were arterial ischemic strokes. There's also venous clots that can happen in the brain. The majority of these clots are happening postoperatively, so 28% of them are happening post-op. And the majority of the clots that we see in congenital heart disease are within the transverse sinus. Usually in congenital heart disease, we rarely see them progress to basal ganglia infarcts or hemorrhages. Usually we're catching these clots before they progress to actual parenchymal brain injury. And usually our stroke team gets involved quite quickly and they get treated appropriately. In general, cerebral sinus venous thrombosis is associated with smaller birth weight, and there has been an association found between internal jugular venous catheters and cerebral sinus venous thrombosis, with the thought that perhaps having the venous catheters in the neck prevents appropriate blood drainage from the brain. Another type of injury that we also see quite commonly are watershed and deep gray ischemic injuries. And these are generally the more severe type of brain injury that we see that are associated with cardiac arrest or prolonged low cardiac output states. When we have a baby with a basal ganglia thalamic pattern of ischemic injury, so like this, and again, the brightness indicates an abnormal basal ganglia and thalamus area. These children this type of injury is associated with the worst outcome in these children, commonly presenting with things like cerebral palsy and epilepsy long-term. When it's more of a watershed pattern like this or like this one, the outcomes are actually quite favorable and more related to long-term cognitive and language disabilities. I'll also briefly mention hemorrhage, which we see quite commonly in congenital heart disease. When we think of intraventricular hemorrhage, they're actually quite rare in congenital heart disease, and mainly they are low grade. So we're usually not seeing anything above a grade 1 or a grade 2 intraventricular hemorrhage in congenital heart disease. And usually they're just associated with preterm birth. And the literature hasn't indicated any difference between pre and post-op incidence of intraventricular hemorrhage. So this image here is an example of where a baby had a grade 3 intraventricular hemorrhage here on the right side. We also see subdural hemorrhages very commonly in our imaging, and we're seeing that in about 43% of infants with congenital heart disease. It seems to be related to vaginal delivery more than anything else that we've been noticing. And the majority of these subdural hemorrhages resolve by 3 months of age. We rarely see that the subdural hemorrhages progress to becoming significant hemorrhages where they're causing compression and midline shift on the brain. And then the last type of hemorrhage that we see that is obviously the most significant is an intraparenchymal hemorrhage, when we actually have a hemorrhage within the brain tissue itself. And this is something we see in patients that are on mechanical support or anticoagulation. So patients on ECMO or who have a ventricular assist device are more commonly to have intraparenchymal hemorrhages, usually because they're on higher and long-term doses of anticoagulation. Sometimes they will be related to an underlying vascular malformation of their brain as well. I'll briefly mention microhemorrhages because they are something that we see very commonly on our post-op imaging of children with congenital heart disease. So if you look at these images, you can kind of see these tiny little dark circles scattered throughout the brain in the top and bottom images. They're like very perfect little dark circles, and those are what usually get reported as microhemorrhages. We see them very commonly post-op, and it's thought to be related to the surgery on cardiopulmonary bypass. The mechanism isn't quite clear, and the impact on long-term neurodevelopmental outcomes is also unclear. There have been some papers reporting that the severity of microhemorrhages is related to long-term neurodevelopmental delays, but other groups haven't seen that correlation. And I would say our cohort here at SickKids, we haven't found a correlation between the microhemorrhages and long-term neurodevelopmental disability. And while this isn't an injury, I also wanted to just mention the long-term white matter volume loss that we've been seeing in neonates with palliated hearts or that have a delayed repair of their cyanotic CHD. So this is an example of a baby with hypoplastic left heart syndrome. And he was part of one of our research studies. So he had 3 brain MRIs done. He had a pre-op, a post-op, and then he had a follow-up brain MRI done around 6 months of age. So the pre-op MRI was normal, and I'm just showing you the post-op MRI where we can see was also normal. You know, not that impressive of an MRI. And then when we scanned him again at 6 months of age, we can actually see that there are significant extraaxial CSF spaces that have shown up. And then when we look at the white matter in the frontal areas, we can see that there's been quite a bit of volume loss. The ventricles have also increased in size due to that white matter volume loss. So that's an interesting pattern that we've been seeing in children with cyanotic lesions or children that have delayed repair or palliated hearts, that they're kind of showing up with this pattern of white matter volume loss despite not having any brain injury. If we saw, you know, ischemic white matter injury or a watershed pattern of brain injury, we would kind of expect to see some volume loss. But this child had no brain injury, and now we're seeing this interesting pattern of frontal white matter volume loss. And this actually correlates a lot with the head circumference growth trajectory in a lot of these children. So this was the same baby when we plotted the head circumference, and you look at the trajectory over time, you can see that while her brain is still growing, the trajectory has really dropped off the original percentile where she should have been at. Technically, babies should continue to follow a percentile as their head grows, and you can see that she's really dropped off the percentile that she should have been at, and is now well below the 3rd percentile in terms of her head circumference. So we've got a problem. So what are we going to do about it? And I love these comics. I think they're funny. So instead of just complaining about it, you know, we really need to focus on looking at our modifiable versus non-modifiable risk factors to improve the neurodevelopmental outcomes in our children with congenital heart disease. So there are a lot of non-modifiable things that we can't really change. So if the baby's born preterm, or if they have a genetic syndrome or the type of heart lesion that they have, some of these things we have no control over, but we can look at other things that we do have control over that we know impacts brain growth and long-term neurodevelopment that we can choose to focus on. And a lot of the focus has shifted to this perioperative period. So previously, a lot of the focus was on the intraoperative period, back when people thought it was really the bypass and the deep hypothermic circulatory arrest that was causing these neurodevelopmental disabilities. But as we've been doing more research, we know that there's a lot about the pre-op and the post-op period that we could change and improve their outcomes. So I'll kind of go into a couple of the strategies that other groups have been working on and that our group has been working on to see how we can improve these children's outcomes. So this is a paper coming out of Mike Seed's group here at Sick Kids. And essentially what they did was they plotted the brain volumes and the language scores based on timing of repair. And this was a cohort of children with transposition of the great arteries. They compared the babies with TGA with intact ventricular septum, which usually tended to have an earlier repair in the neonatal period, to the children with transposition of the great arteries with a ventricular septal defect, which generally had a later repair at around 6 weeks of age. And when they plotted the brain volumes of these children, because as our program already has pre-op and post-op brain imaging in these children, they found that the brain volumes of the children with the early repair were much better than the children that had the late repair. And that makes sense with those two images that I was showing you with how the brain looked post-op in that child with single ventricle disease and the patient with the white matter volume loss, 6 months down the road. And that was in a child with unrepaired CHD. So that would correlate with these children with the VSD who are having later repair. And then when they looked at the language scores, they found that the language scores were significantly lower in the children that had a later repair as well. So maybe the timing of surgery, maybe if we focus more on doing earlier repair in these neonates with transposition of the great arteries, we may be able to improve their outcomes. Another thing that has come up in the literature is prenatal versus postnatal diagnosis. And this study came out of the UCSF group by Shab Pevandi. And they looked at a group of a wide variety of children with congenital heart disease, from transposition of the great arteries, hypoplastic left heart syndrome, and many others. And they found that in the children that had a prenatal diagnosis of congenital heart disease, they actually had less brain injury compared to those that had a postnatal diagnosis of brain injury, of congenital heart disease. And then when they also looked at the fractional anisotropy of these children, comparing the prenatal diagnosis to the postnatal diagnosis, prenatal diagnosis being the yellow line and the postnatal diagnosis being the blue line, they found that these children that had the prenatal diagnosis also had more mature and better developed white matter. So if we can do more prenatal diagnoses and catch children with congenital heart disease prenatally and less postnatally, then that is also brain protective as well, and we may be able to impact the outcomes of these children as well. A lot of other groups and our group here at Sick Kids have been focusing on inpatient developmentally supportive care. That's working towards making a better environment for these children, especially when they're spending weeks to months in the ICU, but also focusing on empowering parents, having them become a key part of the medical team, and helping them become more involved in their child's care and take ownership and leadership of their child's development. So these are a couple of images of many of our patients here at Sick Kids, we can see, we've been encouraging parents to become involved, also having other programs like music therapy and pet therapy that's helpful for the patient's development. And then also focusing on things like parental holding and skin-to-skin holding to encourage ongoing brain development. I won't go into this in too much detail because I'm sure at some point you'll hear from our therapists who are definitely the experts in this. And then a lot of programs have also implemented cardiac neurodevelopment follow-up programs similar to our program here at Sick Kids, where there's specialized teams providing routine scheduled neurodevelopmental assessments. And these are happening at different points in the child's life because we know over time, children's developmental needs change, especially in the congenital heart disease population. We know that early on, they need more support with their motor skills. And then as they reach school age, it's more support with their cognitive and language skills. These programs also provide a lot of education to families and help with accessing community services to support ongoing neurodevelopment. And usually these are made up of interdisciplinary teams with lots of therapists, psychologists, and pediatricians as well. And then again, I keep highlighting this, but the parental support and parental empowerment is a huge piece of supporting ongoing neurodevelopmental care. So as I wrap up my presentation, in summary, neurodevelopmental disorders are common in infants and children with congenital heart disease. And as we know, neonates with congenital heart disease have impaired brain development that starts from the fetal period. And this impacts their white matter maturity and their white matter microstructure. And because of the immature brain in congenital heart disease, the brain is more vulnerable to both preoperative and postoperative brain injury, particularly ischemic types of injuries. And our program here at Sick Kids and many other institutions in North America and around the world have developed cardiac neurodevelopment programs to support the neurologic and neurodevelopmental care of these infants so that they can improve their outcomes. And then lastly, there's still a lot of work to do in this area. So as we move on, hopefully we'll come up with more strategies on how to address those modifiable risk factors and improve the outcomes of our patients. And lastly, I'd just like to acknowledge all the people that have been very key in supporting the neurodevelopmental and neurologic care of our children with congenital heart disease. And you'll be hearing from many of these individuals throughout today as well. Thank you. I'll open it up to questions now. Yeah, we have 10 minutes for questions.
Just see if there's any in the chat.
Oh, thanks.
All right, it looks like perhaps there's no questions. Vanna, I'd like to really thank you for starting off this day. And since you've come into this role, we're really moving forward in the ICU in terms of neurodevelopmental care. So thank you.
Thank you. I hope you all have a great day.